Okay. So let's continue. So the next imaging modality is CT. So let's see what we can do with CT for cardiac imaging. So one of the nice things of CT is that obviously that it provides a 3D data set. So what we can do is we can scan the volume of the heart, or the thorax part where the heart is located. And then later on we can process it. And so in order to look at especially coronary arteries, what we need to do is we need to try to follow the trajectory of the coronary arteries. As you see here, so here is an example of the segmented coronary arteries from a CT image. Keep in mind that this is after contrast agent. So because you can only see the vessels on CT when you inject contrast agents. Here, the advantage is that you do not need to do this inside the coronary. Because the fact that the problem with catheterization is that because you're using projection, that everything would project on top of each other. With CT, because we really have a 3D volume, we don't care if there's also contrast in the venous circulation, because we can actually separate it. And so what you will see is here, one of the things that you see also is already the difference between the resolution. So what you saw is that with coronary angiography, we can see all the smaller vessels and bifurcations. Here with CT, we can only see the larger vessels, only the proximal part. Now for disease, this is often enough. Of course, for treatment, that is something different. So the thing that we can do now with CT is what we can do first is we can try to segment these coronary arteries. And then the nice thing is you can use image processing. So what you can do is you can determine the center line of this very kind of tortuous vessel. And then you can actually virtually stretch it open. And so you can really, from this kind of 3D structure, in order to do measurements and to see where you have abnormalities, you can really stretch it open virtually. And so this way you can nicely evaluate the whole vessel, and you see here nicely how this is tapered. Always keep in mind it's the proximal part, of course, that you do. So this is like a nice interaction between, on the one hand, 3D image acquisition and then image analysis and processing in order to properly visualize the structure that you want to look for. Here are some examples. So here you see, for example, clearly the difference between this is a vessel that is imaged by angiography, so the traditional projection X-ray, and this is the same one which is done by CT. So you can see the differences in the spatial resolution. But you can see with CT that there's a narrowing, so that is quite important. And one of the interesting things that you can also see with CT is you see all these white dots here. And so now you think about, okay, this is white dots which are highly absorbing. So that means that the material has to be either can be the contrast agent, it can be metals, or it can be bone. So these are the ones which are highly absorbing. You see it's irregular. So it's unlikely that's a metal structure, because metal would likely be regular. It's also unlikely that it's contrast with this kind of distribution. So the only thing that it can be is still is bone in some ways. Now the question is, can this be bone? Well, keep in mind that when we look at bone, we're actually looking at calcium. So what you see is these are actually calcifications of the coronary artery plaque. So coronary artery, the atherosclerosis, as I said before, starts with lipids, but then if it continues longer and longer, what you have is you get local calcification also. And so you see here calcium distribution within the coronary arteries, and you see also the narrowing. Now, one of the things that is so relevant here is you can say like, okay, if we have calcium, then we have coronary artery disease. So that means that people have developed kind of what they call like calcium scoring to look at the calcium burden of a coronary artery and are trying to link this with clinical disease. And actually what you see is that there's even, and that's done especially like in the United States and so on, they're actually promoting this as like a screening tool. It's like you say like, okay, with just a very fast CT image, you get an idea of whether you're going to have coronary artery disease, yes or no. The problem is that this is an oversimplification, and this is what happens very often in medicine. because we are making inferences. So one of the things is we make the inference that what we see with X-ray absorption is the material. So indeed, we probably see calcium. And then the inference is that calcium means coronary artery disease, and coronary artery disease means that we are at risk of getting an infarction. And that's where there's a problem. So because seeing calcium, that means indeed that we have atherosclerosis, but the risk of an infarction is actually not determined by the calcium. On the contrary, because you get an infarction when your plaque ruptures, as I said before. So when you get a rupture of the plaque, and of course, calcium will not rupture. Calcium is extremely stable. So calcified plaques are unlikely going to cause a problem in the future. But they are the kind of a sign that there is coronary artery disease, but it doesn't tell you on whether you have what's called these vulnerable lipid plaques, yes or no. So this is one of the things where, again, you have to be very careful to extrapolate things that you measure with imaging then towards its clinical meaning. You really have to see whether pathophysiologically these are indeed connected. And then, of course, you should show this with a large clinical trial or clinical studies that this is indeed the case. And it has been shown that this calcium scoring, although very attractive in order to use, is not the best in order to do this. But you can nicely see how you can really quantify them with CT, especially these proximal lesions, with the big advantage that you do not have to use catheterization. And catheterization, keep in mind, if you bring a catheter into the arterial circulation, especially when you would start from the heart, when you put it close to the heart, to put anything in the arterial circulation is always a high risk. Because if anything goes wrong, if you form a little clot, for example, around the catheter, or you would bring in an infection, you would bring in a bacteria or whatever, all of this would go immediately to the brain, and you might induce a stroke this way. So catheterization is something you would only do when there's really no other option. And that's the advantage of the CT. So at the disadvantage of having a lower resolution, we have the advantage that we do not need catheterization. And potentially the CT might have a little bit higher dose as compared to diagnostic X-ray, but also we might need less contrast, for example. So it really depends on all of these things. Obviously, in a patient where you almost know for sure that there's a stenosis, which is important based on the symptoms and based on like having ECG changes and things like that, then of course you might go immediately to catheterization because you know that you will have to put a stent. So while the CT you would use at patients where you say like, maybe there's some kind of coronary problems or maybe not, then you would use CT more for screening. That's what I also told you in the beginning. So depending on your, what we call like the pre-test probability of finding something, you might again decide on one or the other because of its advantages and disadvantages. So obviously, since it's a 3D technique, we can also do some kind of direct 3D imaging of these things. Here you see some examples of like the coronary arteries on top of the heart. And here also you see an interesting one. So it looks like there's like grains of rice around this artery. So when you start looking at it, so what you see is these are kind of very bright on the CT. So they're very highly absorbing in this field. So this is a structure, again, which is highly absorbing, which means contrast metal or calcium likely. Contrast, it's never going to be in this distribution. Can it be calcium? Can it be calcifications? Well, it looks a little bit too regular. All of these have exactly the same size and they have more or less a regular distribution. Calcium will never have a distribution like this. So the only thing that keeps this metal, and actually what you also see is you have some more evidence that this can be metal, because what you look at, so this would be a coronary artery. So this is an artery that would bring blood to the heart muscle. But when we follow it, what you will see is that it's actually originating from the aorta, but not close to the heart, but quite away from the heart. This one here is actually originating close to the heart, but this one is much, much further from the heart. So what this actually is this is actually a bypass. So what the surgeons do, if the coronary artery is too much obstructed so that we cannot put stents anymore, it's like it's really too far, what they do is they take an artery out of some other place of the body, and they actually sew it from the aorta, and they sew it onto the original coronary arteries, thus bypassing the problem. So this is called like a CABG, a coronary artery bypass graft, and the surgeons are connecting this actually with staples. So this is literally metal staples that have been used in order to fix this artery around the heart. Here you see another example. So you see the cross section here, and here you see again these little white dots, which are very, very regular. So again, this is likely metal, and this is actually a metal stent. So this is the cross section of a metal stent that has been put here. So again, by combining how much is it absorbing, so what type of material it is, where is it located, what does it look like, what's the regularity, you can see here nicely then the 3D rendering. So these are stents. This is actually probably two stents following each other, which are implanted in order to treat this. So there you can see what's going on. Okay, besides looking at the coronaries and looking at coronary artery disease, what we actually can do is we can also look at CT or use CT for some other things. And one of the things where it's being used currently also is to help guide treatment of some valvular problems. And what you see here is this is an aortic valve. So that's the valve between the ventricle and the aorta. So that's the one going towards the aorta. So that has to open when the pressure is high. So the ventricle tract's pressure is high. The blood should go through the aorta and the aortic valve. And the aortic valve should open in such a way that it's like a very wide opening. Now, what you will see is that almost with everybody, while you're aging, and also depending on your risk factors, what happens is that you get calcification or you get thickening of these valves. And you see that actually because of this thickening and stiffening of the valve, what happens is that the valve doesn't open enough anymore. So here you have some of these very, very thick leaflets actually during surgery. And the result is that the opening becomes too narrow, and you get what we call the stenosis of the valve. And that means that the pressure in the ventricle has to be much higher in order to open the valve and to get blood through the valve. That's fine as long as this is not too severe, but if this becomes severe, then actually you start to get problems with the heart muscle, and actually the heart muscle can get damaged, and you can get to heart failure when this happens. And so what you need to do is you need to kind of fix this valve in some ways. And so there's several ways of fixing this valve, and the traditional one is to do a valve replacement by really cutting out the valve which has been occluded and then replace it by an artificial valve. And so traditionally, so you really, this is like a kind of open chest, open heart operation where they cut open the aorta, then they cut away the aortic valve leaflets, and they actually sew in a new valve. And there's actually two types of valves. One is a metal valve. So where you see you can either have a ball valve or like with different kind of metal leaflets, bicuspid or monocuspid valves. Or you can have what's called biological valves, where the leaflets are actually made most often of pericardial tissue from, for example, pigs or cows. Or you could also have what's called homografts. So these are kind of donor valves. So where you get somebody that died in an accident and has a good valve, these valves can still also be used then in order to replace the valves of others. Now, the problem with these valves is ideally the biological valves, these are the most physiological and they're actually working quite nicely. The problem is that they only last about 10 years. After 10 years, there's leaflets because it's foreign material and things like that, which is, of course, under quite a lot of stress by the blood flow and the pressure. What you will see is after about 10 years, these valves fail. And that means that once you do a valve replacement, that means that this patient every 10 years needs to get another valve. Putting a first-time valve is very easy, is very safe. It's a low-risk surgery. But every time you need to do a reoperation, you have a lot of problems, because first of all, you get the opening of the chest, you start to get a lot of fibrosis and tissue kind of which connects to each other and things like that. And every time you have to cut out this valve, of course, you lose tissue. So one reoperation is fine, but 2 or 3 reoperations become problematic. So that means that if you have a patient with a life expectancy of more than 20 years, for example, when you need to replace the valve, then you prefer not to use a biological valve, but you use a metal valve, for example. But the disadvantage of the metal valve is that you can quite easily get thrombus formation, so that you get blood clots in there. And of course, a blood clot on an aortic valve is really catastrophical, because a blood clot can come loose and can cause a stroke in the brain. So that means that these patients that have this type of valves, for the rest of their life, they have to take pills in order to do blood thinning. And the most commonly used blood thinners are actually also used as rat poison. So that means that you have to swallow rat poison for the rest of your life, which is obviously also not ideal. What they're starting to do now, it's not a solution for both things, but it's to make the operation more feasible and potentially in the future have more easy ways to kind of do redos, is that they actually start with what we call transcutaneous valves. Transcutaneous means that you go trans the cutanea, which is the skin. So from the outside, you can actually do a valve implantation without having to open the chest fully. And so you do that actually by bringing, again, a catheter. And inside that catheter, what you do is you put a valve, which is on a stand, and with a balloon, you put it there in place. And so you can do that either coming from the leg, so put a catheter in the way that you also do a coronary angiogram, and then put a valve there. Or what you actually also can do is actually go with a very small hole in the chest, and then go through the point of the heart, go inside, because the point of the heart is actually very thin. And so it's quite safe and easy to do surgery there. And so this way we can do these kind of implants. And these are very often planned using a CT, because what you need to do is you need to choose. So we have different sizes of these valves. We have different models of valves. So for an individual patient, you have to decide what's the best model, what's the best size in order to put there. So we need to have really detailed measurements of the size of the valve, of the size of the aorta, of the position, for example, of the coronary artery, because if you put a stent and that blocks the coronary artery, you're actually inducing an infarction. So you have to be very, very careful not to touch or obstruct these coronary arteries. Keep in mind, and also, as you can see here, you see these very bright things, so that there's quite some calcifications, because the reason why this valve is not functioning anymore is very often related to the remodeling of this valve, disease of this valve, which is actually very often calcifications. So if we need to put in a stent and then open this valve, if there's calcifications, we might have to break it, or that might actually cause rupture also, so that's important. And also, when we need to put a catheter, so if we put a valve through a catheter, what we need to see is whether we are able to get to the heart. So here is a patient, for example, where you see that in the arteries around the leg, there's a huge amount of calcium there. So it might be that actually related to the fact that you have calcification of the valve, you would also likely have calcification of the vessels, and it could be that there's so much calcification of the vessels of the leg that you cannot put a catheter through it anymore. So then you need to decide whether then to go directly through the heart, as I said before. So based on CT imaging, we can have a very, very detailed kind of pre-operative planning by looking at, okay, what's the size of the valve that we need? Can we get there? And what you even have now is, I don't have a slide of this, but what you see is there's applications where they then even do simulations of different types of valves, different sizes of valves, in order to see, like, if you would virtually expand a valve in this patient, which valve would give you the best result, so that the valve is not leaking, that the valve is not obstructing the coronary artery. The other thing is also that these valves might actually touch part of the wall where you have this, what I said before, this Purkinje system, and thus would cause a problem with the activation, so that the patient afterwards would need a pacemaker, for example. So these things you can actually plan with a proper high resolution CT. Okay. So what I told you before when I was talking about the heart is fiber structure. So having an idea on how cells are organized within the heart is actually very important to understand. Currently, this is very much research related. So we have no ways currently to, in clinical practice, visualize this in a kind of beating heart. But what we can start to do is, well, obviously in the beginning, or originally this was done by microscopy, but as I told you before, what we now have is through synchrotron imaging, we can actually look at phase contrast imaging so that we really can see soft tissues and at a very high resolution. And so here are some examples of how we can use phase contrast CT using synchrotron imaging now in this case in order to look at this fiber orientation of the heart. And the video that you see here, so this is actually a rat heart, where we go from the top of the heart and we slowly move towards the bottom. So we're really making this what we call like these short axis slices. So we really move through this heart in order to see. So you see on top, you have the aorta. Here it becomes the aortic valve, and then you slowly go inside the left ventricle. Here you see the right ventricle, and then you move towards the point of the heart. So you see that everything comes together in the point of the heart. And what you now also see is that actually you start to see this kind of fiber structure. So first of all, I come back to that there's some structure within the aorta, but then you start to see here that within the vessel wall, within the heart wall, you see that there's this kind of, it looks like flow inside, but these are actually these fibers which are crossing, so which are longitudinal, as I said before, at the outside, which are going really circumferential at the inside, and then become longitudinal again at the inside again. And some of the things that you see, you can also see, you see the vessels, so you can follow the vasculature, so you can nicely see all these things that are moving here. These are clearly vessels. And you see also how these muscle fibers are actually spiraling then towards the point. And you see this also jumping in the end. So these are these kind of tendinous structures which are there and you can look at. So with phase contrast CT, we can really look in very, very much detail at the structure, and we really can see all these trabecular structures also. Right? So here you see an example of here you see these really trabecular structures. And here you see a nice example and kind of volume rendering of the apparatus around the valve. This is in this case the tricuspid valve, so between the right atrium and the right ventricle. And so you nicely see here these heart strings, which are then connected to these bulbs of the heart muscle. Also, this gives you, this is in this case, actually, this is using contrast agent, but you see some vessels without contrast agent, but here it's actually Chinese ink being used as contrast agents in a rat heart. So you really see how the coronary circulation is going from the big vessel at the outside, and then you see it really branching towards the inside, and you see actually how dense the coronary system is. So this is the coronary arteries in like a very thin slice with the heart. So here you see them going through the heart kind of fully in order to be able to bring the blood through all the parts of the heart muscle. And so that is really important. And so this way you can visualize this also at extremely high resolutions. This is actually a segmentation of the coronaries now without using a contrast agent. So this is the advantage again of phase contrast imaging, where we can see vessels without contrast agent. So in the future, at the moment that we can get phase contrast effect in our CT images, we should be able to, without contrast, really looking at the vessels and looking at stenosis, for example. What you see immediately also is that image processing is very important there. So you need to do segmentation based on image processing, and then visualization and kind of quantitative analysis using computer vision is something which is really relevant in kind of contemporary medical imaging. But of course, looking at this fiber orientation is interesting. And again, with image processing, what we actually can do is we can actually locally try to detect directions of structure. So we can calculate what we call the structure tensor imaging based on gray values, where we really look at how the contrast is changing. And from this, we can actually extract fiber orientations and then quantify this. And one of the things that you can see here, so this is actually, these are human fetal hearts. This is actually a normal human fetal heart, where you can really see what I told you before, is that from the outside to the inside, you have this gradual change in direction. So the color here corresponds to the angle at which the local cells are oriented. And you see that that's also very homogeneous, not only from the outside to the inside, but also from the valve plane towards the apex. So everything is very, very homogeneous. And this, for example, is a heart from a fetus that had severe kind of congenital heart disease, so severe abnormality in development of the heart. This was actually a fetus that instead of a left and a right atrium had two right atria morphologically, also had the left and the right ventricle switched, and then had like a big hole between the two ventricles, and actually also had that the kind of mitral valve and the tricuspid valve were actually fused. So it's really a very, very severe abnormality. So that's also why the fetus died in utero. What you see now is that when we look at this fiber orientation, you see that here, this kind of left ventricle morphologically, but it's flipped, as I said before. You see one wall looks reasonable, with is homogeneous and fiber orientation. But when we look at what's called the septum, so the wall between the left and the right heart, we see it's actually totally messed up. And even worse, this right ventricle is absolutely totally messed up. And so now you can understand that if this baby would get born with a heart like this, and with actually, in this case, this right ventricle connected to the aorta, you would see that this would be a very, very inefficient heart, and this baby would immediately go in heart failure. And so by using this kind of analysis, where we really look at what you can see with phase contrast imaging and then do image processing in order to get fiber structure there out, we can really try to understand what happens in certain abnormalities. Here is another example. So this is actually an example of a fetus that was having a single ventricle. So instead of two ventricles, having like just one. What looked like the pathologist for one ventricle, actually what you see is there's like still a very slit-like, very, very small left ventricle available. And you can nicely see this in this fiber orientation also. So where you can see that now you actually have this double change there locally in what looks like one roll. So again, while in principle, this is reasonably okay. If these children are born, they can live up to 30, 40 years without any problems. Mostly afterwards, they also need a heart transplant. But what you will see is that actually this can cause problems that, although it looks okay, when you look at the microstructure, it can be not okay anymore. And so by doing this at high resolution, we can really look at all the different levels. We look at the whole heart sizes, and we can really look and go into detail. And you can even image up to single red blood cells in this way in like intact hearts. Here you see some other examples. We really can look at cellular level with this kind of imaging in large chunks of tissue. Or what is very important also is one of the problems that you have in the heart, which can be caused by some problems in the perfusion, so with coronary artery disease, but many other diseases, and for example, also long-standing hypertension can induce this, is what we call like fibrosis of the heart. So that means that your muscle tissue is partially being replaced by fibrous tissue, which is of course bad, because first of all, that replaces cardiac contraction cells, so you have less contraction. But what is more important is actually it makes the heart stiffer. And having a stiffer heart is actually quite bad, because what happens is that, so you have to keep in mind that when we look at the cardiac cycle, so what happens is after the electrical activation, we have the contraction and we have the ejection. But then actually we have kind of an elastic recoil first in order to get the filling. So a lot of the blood comes in again in the ventricle by first elastic recoil of the tissue, and then secondly with atrial contraction. Now this elastic recoil becomes very inefficient if we have this fibrosis. And so detecting this fibrosis and knowing where it comes from is actually also quite important. And we still don't have ideal ways of doing this, but we try to do this, or we try to infer this. But again, with this phase contrast imaging, we can actually direct image this. And here you see, for example, this would be normal tissue. This would be tissue of hypertension. So this is, in this case, a hypertensive rat. where you clearly see that you see much more of this white structure, and you see when you segment it, it's much more obvious. So this is like fibrosis induced by high pressure. And here you see a lot of fibrosis, and this is actually induced by a local infarct. And so you can really quantify this in this way. And you can nicely see actually how CT images in this case can actually mimic or actually show the same information as histology. And so again, also you can look, for example, this is an example of actually tissue from a patient that was actually operated on, a patient with this hypertrophic cardiomyopathy. And so that has this genetic mutation that makes that it gets this abnormal fibers. What you have is that some patients can have such a thick wall that actually the wall is starting to obstruct the heart internally. So if the wall is so thick that it actually starts to be an obstruction for the blood flow to go out, then you need to do surgery and cut away some of this tissue. And what we're currently doing in clinic is we kind of collecting this tissue and then do also this kind of synchrotron imaging. And here you see an example. This is actually a patient where they had to cut away tissue because the patient had so much hypertension that the wall became too thick. You see that there's a regular structure of the cardiomyocytes, and you see this large sheets of fibrosis coming. And this is a patient with a genetic abnormality where you clearly see that the cells here are crisscross and totally changed. And you actually see that the vessels are also much bigger. And then again, we can use image processing to segment this and then to do 3D visualization, where you can see that in a hypertensive patients, you have a lot of fibrosis, but in a regular way. While in this kind of genetic abnormality, you see that it becomes like totally disorganized, and you get this fiber disarray in some ways. So these are ways to try to understand much more what's the underlying tissue. At this moment, this is research, but theoretically, with phase contrast CT, we can go to that type of imaging. Yeah? Here you see an example actually of a vessel wall, in this case an aorta, being imaged, where you can nicely see this this is actually the elastin fibers, so the ones that cause the elasticity of the wall, because as I said before, the vessel wall needs to be able to expand when needed, but also the vessel wall needs to be elastic, because with every heartbeat, what happens is that the blood is being pushed into the aorta is expanding a little bit, actually in order to buffer the pressure wave for the output. And that's done by this kind of elastin fibers. And here's an example. So this is actually aorta from mice. This is an example of another genetic abnormality where you have what's called Marfan syndrome. What you see there is that they get fragmentation of this. And because of this fragmentation, when you look at the whole wall, you see you get really kind of holes in this kind of elastic material. And these type of patients, when they're 30 or 40 years old, they mostly get severe dilatation of the aorta. And they need surgery because the bigger the aorta becomes, the bigger the potential that it will kind of rupture and break. And then, of course, you get an enormously big problem. So here, by looking at this, we can really try to understand what the underlying reasons are and how this is actually kind of taking place during life. Okay. If you have any questions, just ask. Yeah? Okay, we can go to the next imaging modality then. That's nuclear medicine. We're going to keep that short because nuclear medicine at this moment, while it's still a very important modality in clinical practice, for cardiology, it's actually being used less and less. But the most important with nuclear medicine is that, as I said before, what you can do is you take a radioactive molecule, you bring it inside the body, and you try to trace it. So it's a radioactive tracer. The advantage is that you can almost make any biological molecule, make it radioactive in some ways. And so you can really target different molecules, target the dynamics of molecules, and so really target the biochemical processes, and so directly the metabolism in the body. The disadvantage of nuclear medicine is, of course, that the spatial resolution is awful. It's more in the order of centimeters rather than millimeters, what we really want. And so we see that it's often combined with other imaging. When we look at the heart, what used to be the case, and still is being used a little bit, but less and less, is, for example, perfusion imaging. So we use a tracer that can measure how much blood flow is going to different types of tissue. And so we can really measure perfusion defects that are induced by a stenosis, for example, of the coronary artery. And very often we can do this with a kind of stress test. So it's mainly an adenosine stress test. And what it does is, with the stress test, what you try to see is, are the vessels already fully dilated, as I said before, or not? So we image the patient at rest, then we give a drug that would dilate fully the coronary arteries, and then we would again do an imaging to look at perfusion. And the vessels that were obstructed and already fully dilated will not react, and other vessels will react. And so by comparing the blood distribution before and after this dilatation, we can have an idea of what's going on. Currently, as I said before, this is still being used in clinical practice, but less and less because the equipment is expensive. And of course, we need radioactivity in order to do it and get it at relatively low resolution. When we do PET imaging, actually, we can also do dynamic PET imaging. So we can really look at a beating heart. But keep in mind that this is very triggered. So PET is a very slow imaging modality. So again, in order to do this, we need to kind of trigger this, and we get a very bad temporal resolution also. But it is possible. But the nice thing is that we also can look at the dynamics of injection. So if we inject the radioactive tracer and we start image immediately, what you see first, very shortly after injection, we see that the contrast comes in the right ventricle. A little bit later, it comes in the left ventricle, because we do an injection in a vein. So vein, the blood comes first in the right ventricle, then goes around through the lungs, comes into the left ventricle, and then goes to the rest of the body. So first right ventricle, then left ventricle. And then we know that if we use a tracer which is being taken up by the cells, then we see that it's being taken out of the blood and will start to accumulate within the tissue. And then after 20 minutes, we see, for example, it's fully accumulated in the tissue and nothing is in the blood anymore. And now by measuring the dynamics of how fast this is being taken up as compared to how much we have injected, we can actually really quantify, and that's what has been said in the class of nuclear medicine, we can really quantify exactly the amount of blood or the amount of glucose that is being consumed by a piece of tissue. So nuclear medicine is the only fully quantitative modality where we can quantify this type of metabolism and function in some ways. So as I said before, the resolution is awful, which means that currently, actually, nuclear medicine scanners are always integrated in CT scanners. So a PET you cannot buy anymore. You buy a PET CT scanner or a PET MR scanner. And this is one of the first original images where this was. So you take a CT or an MR for the anatomy, and then on top of that, you put metabolic information, which is measured by the PET. But as I said before, this is only used limitedly currently in cardiology. Nuclear medicine is much more for brain imaging and for example, oncology, tumor imaging. That's the biggest application. Okay. But then the workhorse of cardiac imaging is actually echocardiography. And the reason for this is, first of all, that it's non-invasive. So you don't use ionizing radiation. And in cardiology, because it's really typically a chronic disease, we need a lot of follow-ups. So you need an imaging modality that is not inducing extra harm over time. Additionally, ultrasound is quite cheap, so because we have a lot of patients, so we need a lot of imaging modalities. So we can have like tens of ultrasound machines in the hospitals. We cannot have tens of CTs or MRI scanners. Typically, you have maybe 2 or 3 MRI scanners in a hospital, which has then to be used by all disciplines. So, for example, currently in clinic here in Barcelona, we have one dedicated scanner for cardiology, and dedicated means that half of the time we can use one MRI scanner for cardiac applications. And the other times is being used for brain or bone or muscle or well, kind of joints or muscle, because bone, of course, you cannot see, or abdominal scanning or something like that. And the other advantage, and that is also a major argument to use echocardiography, is that it has an excellent temporal resolution. So because the heart is beating fast, we need actually a high temporal resolution to look at function. So when we talked about ultrasound, we saw that we had different ways of doing imaging, which is actually partially historically evolved, but we are still using. So we have M-mode imaging, we have B-mode imaging to make tomograms, and then we have Doppler imaging to look at velocities. And we can do that with color Doppler, and we can actually also look at velocities of the muscle. Nowadays, we can also do 3D imaging, but all of these different ultrasound sequences are actually actively being used in cardiology. So when we look at M-mode imaging, so what we can do is we can look at the motion of the tissue within one line over time with a high temporal resolution. And so we see here, for example, how the walls of the heart are moving towards each other and away from each other during the cardiac cycle. As you see, always with regard to the ECG. So in principle, in any cardiac image which is moving, we need to know where we are in the cardiac cycle, and we do that actually through the ECG. Here are the typical B-mode images that we get. So depending on where we put the transducer on the chest, this is the typical view, which is called apical. So we put the transducer very close to the point of the heart, and we're actually looking upwards. And what you see then is you see the four-chamber view, as we say. So you see the left ventricle, left atrium, right ventricle, right atrium, and you nicely see the dynamics of the valve. You see here the mitral valve, which is moving there. One thing that you see now is if you look at the whole heart, you see that clearly the outside border of the heart is actually not changing. So it's really inside that is moving. And a very important component actually of function is how the valve is actually being dragged towards the apex. Yes, question?
How can we avoid the I don't know the name now, the bones in the chest?
Yeah, the ribs, yes.
Ribs, exactly, yeah.
What we actually need to do is you need to go in between. So what you will see is that the transducer used for cardiology has like about a width of approximately 1 centimeter. And so the space an adult person has about 1 centimeter between two ribs. And what also is the case is that very often the cardiologist puts a probe on and then pushes a little bit in between the ribs so that you actually push away the ribs. But you really have to go in between. So it's the spaces, what we call like the intercostal spaces. So the spaces between the ribs are actually being used for imaging. So that's quite important. So here you see a cross-section is if you would go kind of perpendicular to this view, so you see what we call the short axis view. So you see nicely how the heart is contracting in a short axis. And here again, also, you see the valve kind of flapping in between. So these are very typical views that you can see. Then you can use Doppler, both continuous wave Doppler and pulse wave Doppler. And what we use Doppler for is actually very often to measure maximal velocities, because we know from the Bernoulli equation, for example, that the maximal velocity relates to the pressure drop. So with this way, we can, for example, measure the occlusion of a valve. So the stenosis of a valve, we can measure by measuring the velocities through the valve. Or also we can look at velocities here. For example, this is velocities through the mitral valve in order to see what's the relation between the amount of blood that comes in with what I said, this early elastic filling versus the amount of blood that is being pushed in by the atrium. Because when you get a lot of fibrosis and you have very inefficient early filling, the atrium has to take over. And so by looking at the ratios, for example, of these, we can get information. And then, of course, in general, looking at color Doppler, we can look at, for example, directions of blood. And here you see, for example, this is actually a leaking valve. So because the color determines in which direction we go. So here we see within the ventricle. So if it's red, we see it goes from the atrium towards the apex. If it's blue, it goes from the apex here, in this case, towards the aorta. So you really nicely see this kind of vortex. So the blood is like whirling within the ventricle from the input towards the output. Now what we see here is like actually this is the valve and this will be the ventricle. So we see here blood going towards the aorta, but at the same time, we see that there's actually blood and now green, which is a mixture of red and blue. We see green going into the atrium. So this is actually a regurgitation. So this is a leakage. So there's a small hole within the mitral valve here that makes that during the contraction, blood is actually being pushed at very high velocity and turbulence inside the left atrium. So by doing this, we can actually look at whether there's some valvular problems, yes or no. Here is another way you really look at this abnormal jet, and this is actually a hole between the left and the right atrium. So it's what we call an atrial septal defect, and that can cause problems in some people also. Then another thing that we can do is we can actually measure the velocities of the tissue. So not only of the blood, but the velocity of the tissue. And you can actually prove that if you calculate the spatial gradient of velocities, you can actually quantify deformation. And so we can really measure the amount of deformation taking place. I'm not going to go in detail, but this way we can actually really measure the local amount of contraction and then infer different contraction patterns or abnormalities this way. So this is what we call strain analysis. And so we can use this then in order to look, for example, at local geometry, because I said that this is one of the things to do. And for example, here, what you see is, so this is a patient, this is a normal patient. And you nicely see that this wall is very homogeneous. So it has the same thickness everywhere. And what you see here is actually this patient looks like this bulb here. So you see that locally here at the basal part of the septum, so close to the valve, we see that actually this is thicker than normal. So you have localized hypertrophy. And here it's actually, this is shown with MRI, also different patterns of hypertrophy. And that actually, you can actually start thinking about, okay, why do you get hypertrophy? In this case, it's because of pressure loading. And you can actually kind of infer that if you have pressure loading, you have this very localized thing. We're not going to go in detail to why, but what you also see is that because of this, when we look at deformation patterns, you start to see very abnormal deformation. While deformation is homogeneous normally through the wall, we see that it becomes very inhomogeneous. So this way, you can really look at different patterns and then think about the pathophysiology. So this is what you can infer. We're not going to go in detail, but it's just saying that by doing the proper analysis and doing proper measurements, we can really look at all the different functional changes. And there's other things that we can look at. For example, here is remodeling. In this case, we can also use ultrasound to look either at fetal hearts or at children's hearts. And here is an example of how the heart is actually remodeling when the fetus, while the fetus is still inside the mother, so in the uterus, can have changes in the heart, remodeling in the heart, in this case because of placental abnormalities. So this is an example where the placenta of the fetus doesn't grow enough. That means that the fetus, when the fetus is at the end of the pregnancy, actually doesn't get enough oxygen and nutrition anymore. What happens is that then the resistance of this placenta is abnormal. And what we see here is that this heart becomes much more globular. Because actually this heart, because of the lack or because of the increase of resistance of the placenta and the lack of oxygen, needs to work much harder. It will develop differently. And we can nicely measure, looking at, for example, the sphericity here, how this heart is becoming abnormal. Similarly, we can look at other changes. Here is, for example, how the heart is changing in an athlete that is doing a triathlon. So this is before a triathlon, this is after the triathlon. And one of the things that you can see is that actually when we see now is that actually the right ventricle is actually starting to push away a little bit of the left ventricle. So we see that although this looks like a very normal heart, when doing a lot of sports, what we can show is that you actually can have some problems in the right ventricular side. And this we can really nicely quantify in this way. And so you can nicely compare different athletes, for example. So this is an athlete that even after the race, that looks nice. So the ventricle, the right ventricle, it's not bigger, it's contracting nicely. What you see here is this changed in shape. And it's actually also even visually, you see that this is moving much less. So this way you can do either a visual interpretation of this, and then you can also use different ways to quantify this. And then last, you can also use 3D imaging. Here you see nicely ways of visualizing, for example, the valve or the flow based on 3D ultrasound. While this potentially gives pretty pictures, the problem currently still with 3D ultrasound is that both the temporal resolution and the spatial resolution is much, much less compared to the 2D. So it's much more for fancy imaging than really clinical practice at this moment. In the future, it might be better, but at this moment, this is what it is. So one of the things that I said before is like, okay, ultrasound imaging is more or less real time. But still, in order to really look at these details, what we would like is to have faster imaging. And in order to do full 3D imaging, we also would like to have faster imaging. Yeah? And so what you see nowadays is that there's actually quite a lot of research is in trying to do ultrasound differently. And for example, you can start to shape the beams that you're using. You can start, instead of sending out one pulse, you can start to send pulses in different directions at the same time, and then use kind of computers in order to make this faster. We're not going to go in detail, but there's actually quite a lot of research still going on in order to improve this, to do kind of better resolution, both spatial and temporal 3D imaging with ultrasound. Okay, I think we can still do another break. Let's do a small 10 minutes break, and then we continue. Any other questions? Okay, then I'll see you later.